Hey guys, welcome back. This video is about impression techniques and complete denture. In your clinical prosthetics posting, I'm sure you have taken impressions. We take two impressions, primary and final impression. The preliminary or primary impression is for the diagnosis, and we make a special tray or custom tray on this with the help of stock trays. The reason why when we take impression with the help of impression compound, we don't get the details. Hence, we need to take a final impression. And with that, we make a master cast on which the prosthesis is built or made. There are various theories for impression making. So there's this mucocompressive pressure theory, also called definitive and mucodisplacing theory. You must write these synonyms in exam. Here, impression compound is used. As this says mucocompressive, this technique compresses the denture bearing tissues. Since the tissues are recorded in compressed state, they can withstand functional forces. But what happens is these are recorded in functional form. So after when the patient is speaking or is in rest position, this mucosa or the compressed tissue will bounce back or will rebound. Because of this, there will be loosening of dentures. Here, the pressure is applied manually and we use high viscosity materials in this technique, like impression compound, irreversible hydrocolloids, putty, and heavy body elastomeric impression materials. This is a closed mouth technique because here the patient will bite, that is, will record tissues in functional form or compressed form. As the soft tissues are resilient, they will return to their anatomic position. They will return from functional form to anatomic form. And once the forces are relieved or the patient is not biting or chewing. And thus, the dentures made by this technique tend to get displaced due to tissue rebound at rest. Here, as the patient is asked to bite on the occlusal rim, thus this is a closed mouth technique, because in open mouth technique, the dentist uses digital pressure on the trays, whereas in closed mouth technique or mucocompressive technique, the patient bites on the occlusal rim. The disadvantages are that this technique produces overextended impression. The tissues, they are recorded in compressed state, hence dentures they dislodge at rest or patient is speaking, because there will be rebound of tissues to the resting state. The tissues, they are constantly under pressure, so there will be residual rigid resorption because they compromises the blood supply due to constant pressure. The tissues, they are uniformly compressed and patient pressure is transmitted to even the relief areas. Initial, there is good retention, but there is eventual resorption and loose dentures. Then, mucostatic or passive non-pressure or minimal pressure impression technique as proposed by Henry Page. So, in this technique, the oral mucosa is recorded in resting state. This is based on Pascal's law. And as per Pascal's law, any pressure which is applied to confined liquid is transmitted in all directions. So they considered as oral mucosa is fluid and it is 80% or more composed of water, here we apply Pascal's law. And here free floating materials are used for impression making, that is ZOE and impression plaster. In this technique, oversized impression trays are used with 3 to 5 mm space between the tissue and tray because we are using low viscosity materials or free flowing materials. Here, impression is made with oversized impression tray, spacer is given, but border molding is not performed. Hence, the flanges are shorter in this technique. Interfacial surface tension is the retentive mechanism in this technique. The dentures in this technique are completely or closely adapted to mucosa, but they have poor peripheral seal because we are not performing border molding. This technique is termed as minimal pressure technique because it is impossible to record mucosa without pressure. And impression materials also apply pressure, hence the name minimal pressure technique. We make a primary impression with impression compound, then we construct a special tray with spacer and free flowing materials are used to make impression and no border molding is done here. This overcomes the disadvantages of pressure theory, as when we apply pressure or mucocompressive theory, there will be bone resorption as the tissues will be constantly under pressure. So this theory overcomes that. Disadvantages are that the free flowing material can also compress the tissue, even they can apply little pressure. And that border molding is not done here, so there will be shorter flanges. And closely adapted dentures but with poor peripheral seal, because again we are not doing the bottom molding. So this provides good stability but has poor retention, and surface tension is not only the factor for retention. There are many factors for retention, but here only interfacial surface tension is the retentive mechanism. Last but not the least, selective pressure technique proposed by Boucher 1951. So this combines the principle of both pressure and minimal pressure technique. Here we are applying pressure selectively. That is, the areas that are capable of resisting stress bearing areas, and the pressure is reduced from areas incapable of tolerating stress, relief areas, because the mucosal topography is different throughout, it's not the same. So uniform pressure cannot be applied. This is achieved through design of custom tray. The stress bearing areas, they contact the tray, and the relief areas, they are relieved. Like how? Here, wax is adapted on the incisive papilla and mid-palatine suture in maxilla, because we cannot apply pressure incisive papilla since there are nerve passing through that area, and if they get compressed there will be paresthesia, that is feeling of tingling, numbness or pins and needle sensation. And we put wax on mid palatine suture area, that is, this area is relieved because mucosa is very thin here. Again, in mandible, the wax is applied or adapted on the crest of alveolar ridge, and thus this crest of alveolar ridge in mandible is relieved. Like I said, mucosal topography is not uniform. Some areas will have thinner mucosa, some will have thicker, and thus there is a need for applying pressure selectively. And we achieve that with the help of spacer or using different design of spacer. However, views of different authors on how to achieve selective pressure is different. Let's take this example. The patient has a flabby anterior ridge. So the affected area is marked and blocked out in the preliminary cast, and a custom tray is constructed without involving this area. And the rest of custom tray is prepared similar to this close fitting tray or custom tray with spacer. So this is another example of selective pressure impression. And bottom molding is done to achieve peripheral seal in this technique. The procedure is, we make a primary impression with impression compound, then make a primary cast and place a spacer vac on relief areas and prepare special tray or custom tray. Then we perform bottom molding to provide secondary retention and remove spacer, make escape holes, then make final impression with the free flowing material. This is the most commonly employed technique. The advantages are that this helps in identification of pressure bearing and non-bearing area, but some say that it is still impossible to record areas with varying pressure, and that some areas are still recorded under compression which can rebound. These techniques are very important, especially the selective pressure technique from exam point of view and for chair side vivas. And all the questions pertaining to custom tray, spacer and tissue stop, their significance I'll cover up in the upcoming video. I hope you found this video useful. Thank you for watching and listening patiently.